Thank you. I'm Brandon Hayes-Lattin. I'm a adult trained medical oncologist who has a special interest and specialty in adolescent and young adult medicine. I'm a hematologist and bone marrow transplanter in Portland, Oregon. I'm also on the board of directors for essentially a coalition called Critical Mass, the Young Adult Alliance, which is a spinoff from Livestrong and includes both medical institutions, professional societies, and a variety of advocacy organizations of all sizes who, at least as part of their mission, focus on adolescents and young adults. In terms of crafting solutions, I think at the broadest level, I want to touch bases on three topics, and I'm going to talk a little bit about each of them in the context of fertility, which I think is not only an important survivorship issue, but it's sort of the defining issue, one of the defining issues of adolescents and young adults. So I want to talk a little bit about sharing stories and specifically how we gather data to empower those stories. Sustaining a movement. I think the fact that we're here 10 or 12 years later demonstrates the sustainment of this survivorship movement. But specifically, how do we build capacity to sustain the movement? And then the last is advocacy actions, both in supporting executive and legislative actions, but also in getting involved in help drafting what those might look like. So to start with, in terms of stories and gathering data, I think it's super important to go back to the beginning to think about definitions. So the fact that survivorship is defined from the time of diagnosis, or the fact that adolescent and young adult has been defined, at least in the United States now, as those diagnosed between age 15 and 39. Drafting clear definitions is the first piece to being able to gather the data that we need. But in fertility, this is a particular issue. So if you think about fertility and cancer care, you define patients at risk of infertility based on their treatment exposure or based on their underlying cancer, et cetera. And sort of mirroring survivorship, you might say, well, really anyone who's of reproductive capacity who has a cancer diagnosis is at least at some risk. Another issue of definition that helps define data would be special populations. So once something is defined as a special population, including within our government, that provides certain resources and protections, and that's, I think, an important opportunity. And from that, those definitions, you can create real data gathering solutions. So again, I mentioned I'm a bone marrow transplanter. There's legislation, the Stem Cell Therapeutic and Research Act of 2005 that's been re-upped a couple of times, that really creates a nationwide transplant outcomes registry that all transplant centers are required to participate in. In fact, many payers also reflect importantly on that. And so by crafting those kind of data collections, you can get, what is the denominator of young adults with cancer or patients at risk of infertility? How do we follow what a certain exposure risk relates to successful pregnancies in the future? So next, in terms of sustaining a movement and building capacity, obviously there's been a lot of talk about training and education, and there's a huge range of that, from mandatory certifications to elective recognition for special training. I think our field is really a multidisciplinary one, and I think there's a real opportunity for that sort of special recognition in areas of overlap. So in my world and in AYA fertility, you might think of people who seek special training in pediatric plus adult medical oncology, or onco-fertility, so patients, providers who both get training in oncology but also in reproductive endocrinology. Just as in my world of bone marrow transplant, there is no formal certification of bone marrow transplant, but yet most jobs will reflect positively on that kind of special training and recognition. That then can lead to requiring various accreditation standards, both for individuals and for programs. And again, I mentioned in bone marrow transplant the idea of having to report outcomes, 100-day survival outcomes in bone marrow transplant. Well, actually, that's changing, and we're now needing to report 3-year outcomes to that registry I mentioned. Well, just that change alone fundamentally changes all of the resources my institution puts into the bone marrow transplant program and what long-term follow-up care might be. And then finally, don't underestimate our ability to work together to help craft important legislative and executive solutions. And I want to give two examples. One is um, a bill passed just last month in Connecticut, which amended the requirement of insurance companies there to provide infertility services as part of their insurance package. And the amendment was actually a slight definition, which is that in addition to requiring certain coverage for individuals who were essentially trying to achieve pregnancy for a year and unable, it also adds that those same services must be covered when it's quote unquote medically necessary. And that language then opens up the world to patients who are diagnosed with cancer, who actually, by definition, we hope and assume are not infertile at the time that they need those services. But we know, through iatrogenesis, that we're going to create that risk for infertility. And the last example is one that I think kind of reflects something we heard earlier about financial toxicity, which is it's not just the payment for the treatment in front of you. There is a House bill now called the Deferment for Active Cancer Treatment Act that would, similar to deferments for military service and et cetera, require the deferment of interest and payments to federal student loans when someone is undergoing active cancer treatment. Again, sort of a creative solution that a group like us can get together and advocate